I'm Dr. John Kruse, and welcome to the question and answer hour today. So I'll be reviewing 2 videos that were released in the past week, and then I'll be open for questions, and the questions can be on those videos, other ADHD topics, or mental health in general. And also I'll mention that there is a subreddit, if that turns out to be a better venue for posing questions and discussing answers to questions, you're welcome to do it. That's under Dr. John Kruse. The disclaimer is always that although I try to provide information as accurate as possible, and I am a licensed doctor, the information here is intended for informational purposes, and I'm not making specific medical recommendations. Hopefully, as with anything you find on the internet, you double check or corroborate the things I say here, and that you take this information back to whoever might be prescribing or working with you and have a discussion with them. So the 2 videos that came out this week, one was called Rising Rates of ADHD, and it's undeniable that the rates of diagnosis of ADHD are increasing. It's only fair if you're comparing studies that are using the same methodology and the same patient population year after year, that several sources that do that have found increases in rates of diagnosis of ADHD. Some have dismissed this as to just being due to changes in the diagnostic criteria, changes in greater awareness of ADHD, but I don't find their arguments convincing. The diagnosis argument, the diagnosis was last changed to definition in 2013. There was no surge in the year or 2 after that or step function change in rates, so that doesn't seem to account for it. And ADHD, there has been increase in popular attention to it, but that actually seems to track as following the increase in diagnosis or parallel with it rather than preceding it. And there are numerous reasons to believe that our world is more ADHD-ogenic, or is kindling, encouraging the severity of those who already have ADHD and probably creating new cases. So we shouldn't be surprised that rates are going up. The second video was about, does Ambien cause dementia? So there have been several extremely large epidemiologic surveys, some linking increased rates of dementia with the full benzodiazepine use, people who are using those regularly, and with the Z drugs like Ambien, which is zolpidem for sleep. There are some statisticians and epidemiologists who say when you correct for the fact that these are people who have depression, sleep issues, and others, that the drugs themselves are not contributing to an increase in dementia. There are others take the opposite position, that even with those corrections, there is a linkage. My statistics aren't adept enough to sort out who is accurate there, and maybe nobody can be sure quite yet. But a recent study led by Maken Nedergaard, and she is the neuroscientist at the University of Rochester and University of Copenhagen, who discovered the glymphatic system. So a brilliant new study by her group, and it was elucidating the pumping mechanism for the glymphatic system. So the glymphatic system is the dishwasher of the brain, how we flush away toxins, cellular and biochemical debris. That happens during non-REM sleep, and actually only during non-REM sleep, during circadian phases when you're expected to be sleeping. So a big nap during the day probably doesn't engage that system. And this recent study using fiber optics in mice, so they did not need to use anesthetized mice, rodents, and other studies that can confound what's a sleep effect, what's an anesthetic effect. What they found is that in the locus ceruleus, there's a cyclical surge in norepinephrine release, which is on the order of about 50 seconds, which is a very slow, coordinated pulsatile release. That's causing constriction of tiny arteries throughout the brain. The arteries constricting causes shrinkage of tissue, shrinking back, allowing cerebral spinal fluid space to increase. And given that that's happening on a rhythmic pumping basis, that's the pump for the system. So the side aspect, but the one that seemed to get more media attention, was they also went on to treat some mice with Ambien and found a approximately 30% reduction in proteins being flushed away or washed away by this system. And that's a considerable decrease. So there's a plausible mechanism by which Ambien may be impairing the glymphatic system. And we know the glymphatic system is responsible for flushing away amyloid plaques and plot tangles, which are hallmarks of Alzheimer's. Again, just because there's a plausible mechanism of action doesn't mean that's actually what's happening in people. And it's not even clear whether the 30% reduction is a clinically meaningful. If your dishwasher is on 70% power rather than 100%, are all your dishes getting clean? Are all your dishes getting clean enough? It's a loose analogy, but an interesting one. The other aspect is that people who are taking these drugs are people who have pre-existing sleep problems, so it's still not clear whether just having uninterruptedly bad, deficient sleep is worse than being on Ambien. So this doesn't mean everyone should stop their Ambien because it's causing dementia. So I see a whole bunch of questions. I did want to get back to two questions that were posed at the end, or one was, I guess, in the middle of the last session. One was from Dennis, and Dennis had asked whether there was any evidence whether amphetamine-based products affect dopamine synthesis. And my off the top of my head response was I wasn't aware of anything. And with further investigation, other than, again, an indirect by affecting dopamine levels, there are feedback loops that then can have an effect on rates of synthesis. But I can't find any evidence that amphetamines themselves are directly interfering with any of the steps in the synthesis of dopamine or any of the enzymes involved there. And then the second question that had came in from Frank, and he was asking about issues regarding controlled prescriptions, I guess particularly in California, and why that seemed to be harder to do. So over the last few years, sort of in the post-COVID world, the DEA has continued to crack down on controlled substance prescribing. This is largely a response to the opioid epidemic, but the DEA clearly sees very strong parallels between the opioid epidemic and a rising amount of prescriptions for stimulants, as well as rising amount of intercepted illicit stimulants coming into this country. So they are happily cracking down on and trying to suppress unnecessary controlled substance prescribing. Most of those measures and problems are the problems paperwork that they create are directed actually at pharmacies. So they have much more paperwork to justify what their stores are doing. But there's also somewhat indirect pressure on doctors. So doctors know that they are being much more closely scrutinized in databases, that both insurers and the DEA and state licensing boards have information about prescribing patterns. So the specific laws or rules have not actually changed, but doctors are more wary, and many of them, particularly if they're not comfortable, if they don't have enough experience with prescribing opioids or stimulant medications, will just make blanket statements that they won't do that. Dennis asks, how do you differentiate ADHD from the cognitive deficits present in schizophrenia? And he further qualifies his question as wondering whether ADHD in this population is truly ADHD discretely or deficit-related parts of the schizophrenic spectrum. So it's a good question, and one that I think our answers will be changing in the years ahead. So our current diagnostic system, and I'm talking largely about DSM-5 in America, that's Diagnostic Statistical Manual of Mental Health Diseases. It has close parallels, but it's not identical with ICD-11, which is the Worldwide Health Organization Diagnostic Manual. And currently, these are symptom derived diagnoses. So you have to have a certain number of symptoms, and there's a rule out that if you have the symptoms can't be due to another condition. Interpretation of the information we have is that there is real overlap, not just superficial overlap. And by that, I mean real overlap is that both ADHD and schizophrenia, as part of what they are doing, is affecting prefrontal circuits that are highly involving glutamate and dopamine, and that the impairment of these circuits can affect control over attention, can affect working memory, can affect impulse control, can affect a whole host of executive functions that could be impaired in the two of these. I mean, overall, the collection of cognitive and executive function problems in schizophrenia tends to include a large amount of apathy, a lack of ability to initiate any actions classically. So there's some overlap, but the flavor or the emphasis seems to be substantially different. Not that there aren't people with ADHD who have major problems with initiation and motivation. The deeper question is, should we be calling, if someone has complete set of ADHD symptoms and schizophrenic symptoms? Do they have two different conditions? Do they have just a variant of schizophrenia that's more ADHD-like? They have a variant of ADHD that has elements of psychosis. I think our whole system is going to be changing in the years ahead. So that may be a non-answer answer. So James Alexander asks essentially whether there's tolerance to Intuniv. So the question is, if one went up as fast as the fastest recommendation of 1 milligram a day per week, presumably starting at 1 milligram the second week, going up to 2 milligrams a day, might you wind up at a higher dose that eliminates your tolerance for a lower, or the ability of the lower dose to perform? And his example was whether 2 milligrams a day might be less effective after someone spent some time on 6 milligrams a day and then one went back down to 2 milligrams a day. I'm not aware of any rigorous research done on tolerance to guanfacine. It's certainly possible. Thought is that the mechanism by how it's working is involving synaptogenesis in the prefrontal cortex, slow processes that take a while to build up and not as closely tied to just drug levels at a certain receptor site at a certain moment. So theoretically, maybe there's somewhat lower likelihood of tolerance. I'd say clinically, one is that again, because guanfacine's effects are slow and indirect, and that people don't tend to feel revved up from it. And many people count on that revved up feeling to tell them, aha, my Ritalin's working, my Vyvanse is working right now. What I can say is I haven't seen people who clearly were getting some response at 2 who went to a higher dose and then went back to the 2 and didn't get that response. I've certainly seen people who had some response at a lower dose and were hoping for more, and some who got a bigger effect at a bigger dose, and some who didn't, who then were able to go back to the lower dose and continue with the benefit they'd gotten before. Is it likely that being on a diet that limits your daily calories to the bare minimum recommended by the FDA, 12,000 for a woman or 15,000 for a man, will prevent stimulant, non-stimulant medication from working or make dose changes less noticeable? One is, again, I don't know of any direct research looking at caloric restriction and the impact that has on stimulant efficacy or tolerance or detectability of function. Don't know of any hard data on that, and I'm not aware of a clear prevailing reason why that might help. So Borislav is asking us to narrate, maybe at some future time, because I'm not aware of the study, active noise suppression. In one study, had effects on the brain and caused neurodevelopmental issues, shrinkage, etc. I mean, I do have a talk on a maybe related issue of about 2-3 years ago. There was a big craze in brown noise using MAT. So it's like white noise, but more more bass, essentially, more rumbly, more deep end of the audio spectrum, using that to enhance performance in people with ADHD. There's, I believe it's a Swedish group that's done a little bit of study, small numbers of people, but consistent results with white or brown noise, I think mostly white noise, suggesting discrete periods of white noise can enhance attention, concentration, and executive function performance in people with ADHD. The testimonials about brown noise where people were raving how wonderful it was in terms of helping calm them and soothe them. And again, not just calming and soothing, but helping with focus, concentration, a whole host of ADHD symptoms. Before my article on Medium and my video here, I haven't seen other people talking specifically with brown noise about one potential downside. This is not a proven downside, but one of the leading researchers on neuroplasticity, Michael Meltznick, I'm going to butcher his name, I'm not remembering. He has written extensively about white noise listened to continuously maybe being similar to tinnitus. And tinnitus, actually, because it's activating lots of circuits simultaneously, is exactly geared to what you don't want. I mean, the nervous system is designed to pick out specific things and respond to them, and increasing signals throughout the brain actually is associated with degradation of systems in a way that resembles dementia-like degradation of systems. So listening 24/7 to brown noise is not something I'd recommend. If you're going to listen to noise-canceling noise, I would suggest something much more varied, like natural sounds, whether it's a babbling brook or other sounds, which are probably less damaging, potentially damaging. James Alexander again, if practically every ADHD medication belongs to a class of drugs linked to reversible cerebral vasoconstriction syndrome, how common are RCVs? I mean, so there have been, I do have a talk on video on cardiovascular implications of stimulants. And there are some people who have problems, but they are quite uncommon even after years of use. The study that I'm thinking of found some increasing rates over the first several years, but the absolute rate of problems was still quite low, and probably people with ADHD are already predisposed to a whole host of other health conditions, presumably some of those including cardiovascular. So again, on average, the most common variables that are looked at are just heart rate and blood pressure, and on average, people on stimulants or other norepinephrine reuptake inhibitors or SNRIs, the increase is very minor. It's on the order of 1 to 5 points of millimeters of mercury of blood pressure, 1 to 5 beats per minute heart rate. Those are not meaningfully clinically significant for most people. How common are these problems in older ADHD adults who have been on these medications long-term? So part of it is that there are not a lot of long-term studies, but there are a few that look as long as going out 15, 17 years. The question is, are these worrisome for people who want to stay on meds for the rest of their lives? And I would say whenever we're looking at risks, you have to balance costs and benefits. A recent study showing that ADHD on average is cutting 7 to 9 years off a man's life and even more off a woman's life. ADHD kills people through accidents. It kills people through suicides. Yes, everyone believes they're being careful enough or safe enough. They're not going to die through an accident. So the magnitude of benefit in terms just of life expectancy at a group epidemiologic level, stimulants are beneficial to a longer life. Whether among that group are some individuals who are having some adverse cardiovascular effects, that may well be true, but it's kind of like vaccines. With any vaccine, there are some people who have side effects, there are some who have really serious side effects. All of the vaccines, including the COVID vaccines that have been released, and employed in widespread use unquestionably are saving many more lives than they are risking or damaging. Now, is that solace if you're a 25-year-old guy who just got cardiomyopathy from the vaccine? No, that's not very reassuring or happy making. But from a public health perspective, the information we have right now is really clear and robust. The stimulants and other full-blown stimulants, amphetamines, methylphenidate, and other norepinephrine or dopamine boosting drugs are saving lives, not killing lives. DD asks, what makes the default mode network overactivated in ADHD brain if at the same time its nodes are hypoconnected to the precuneus and hyperconnected to the prefrontal regions? What makes it overactivated? Why questions are always more difficult to answer than what. So a couple things here. We use the term default mode network, and I have a talk on that. This is the network that was discovered in the early studies of putting people in MRI machines to look at what the brain's doing during a certain task. The control condition was often, just sit there and don't think of anything. Now, what happens in someone's brain? I mean, most of us are not capable of going into some meditative trance-like completely blank mind state. What happens in the default? So eventually, and it was a researcher at St. Louis, Brakely, found that there was actually a commonality in this across different studies to brain regions that were being activated when subjects were being told just to not think of anything. And default mode network is what's engaged not when you're involved in working on a specific task and not the system for detecting what's salient or important, but when you are just sort of meandering in your thoughts. Many of the thoughts are self-directed, relationship-directed. They may be current time. They may be reflecting on past time, but it's sort of an autobiographical meandering. So one, this is not just one simple linear or even a circular network. This is a diffuse group of networks that are activated. So there are different subsets of the default mode network. Two, when a certain study says it's being activated, the important question is, what is the task that's going on at that time? So some of it is, with ADHD, is suggesting the default mode network, which is usually turned off during task-directed behavior, is more engaged, or at least parts of it are. So again, does that mean it's more engaged all the time? And again, connectivity. Some measures are measuring connectivity in terms of white matter fiber density, and some are measuring just in terms of how synchronized the activity in two different regions of the brain are, and assuming that that means stronger connection. But that is going to, again, that particularly is going to be highly dependent on what task or what the brain is trying to do. James is asking about Guanfacine, and is 4 to 7 milligrams a day the recommended range for an average 80 kilogram US male taking Intuniv? The FDA just says doses above 7 milligrams a day have not been evaluated in adolescents. Body weight in many across psychiatry has not been a particularly, it's not that there's no correlation, but it's a pretty weak correlation. So there's lots of factors, and I have a talk on this in terms of, I'm not remembering what it's called. It might even just be called related to high dosing and low dosing. There's so many factors that affect blood levels and affect absorption, how quickly your mostly liver enzymes are chewing up a given drug, probably are having a bigger magnitude effect than the actual size of your body and the area that it's being distributed in. There may also be differences in receptor density in parts of your brain. There may be differences in how well the drug is absorbed initially into your body, how well it crosses the blood-brain barrier, and also comparing animal studies and human studies. And young people, kids, have higher metabolic rates. So even though they are smaller, many times they are on roughly comparable absolute number of milligrams for some drugs because they are chewing up the drugs faster, even though that means that on a milligram per kilogram basis, they're actually on a higher dose. So my approach, again, is to focus more on the individual reaction of the drug in your body and not worry about the milligrams and not worrying if you are on a higher than average dose or a lower than average dose. You may have a battle with your insurance company to get something approved, but I would focus on, are you having benefits at this dose? Are you having side effects? Is the ratio between the two of those optimal for you? Rather than, am I responding to a dose that's much lower than people say I should respond to? Or am I getting benefit and no side effects from a dose that's much larger? We know some people will be either end of those curves. As with any drug, I don't know in any field of medicine a drug that works for absolutely everyone who tries it for a given reason. Even though in much of the rest of the body, we have mechanisms of action that are much more mapped out. We have simpler systems where we know most or all the working parts. We know what's going on at cellular levels. Some people will respond and some won't respond. So particularly when you look online and when people are complaining, the other thing to remember strongly is the majority of people who are getting a good result and are functioning and doing well in their life are going on and functioning well in their life. They're not spending hours in chat rooms complaining about drugs that didn't work for them. So could it be some people are being underdosed? Yes. Could it be that some people with ADHD don't recognize an effect because they're associating feeling stimulated with having an effect from guanfacine? Yes. And could it be that some people just aren't really obtaining benefit either because for them, the drug isn't producing the synaptic changes in the prefrontal cortex, or because those changes aren't relevant to what is going on for ADHD to them? I think all of those are probably happening. Hello, Daily Pigs. I recognize you from some comments you wrote. Interesting handle. Do I think there's an optimal target dose of Strattera for adults? I've heard that 1.2 milligrams per kilogram mentioned, but wasn't sure if there's any evidence supporting this. Maybe some of that was answered by what I just said. I wouldn't focus on optimal target dose. I would focus on optimal dosage for an individual. And I do have a talk on Strattera. I think one of the big problems is many people have lots of side effects with Strattera even before they get to a therapeutic dose and never get to a therapeutic dose. And I think it also confuses the whole issue of how quickly is Strattera working, because most people are sitting at a subtherapeutic dose just to make it tolerable for a long period of time. Part of FDA approval for any drug is so before the phase 3 studies, which are looking at large numbers of people who have the condition to see, is it being effective? What side effects are they having? In the phase 1 and particularly phase 2 parts of the study, they look at different dosage of the drug, largely in healthy, unaffected subjects to see what's tolerable and what may be producing some effects. And then the FDA decides to approve the drug based theoretically on the range of the drug that is where benefits are strongly likely to outweigh the side effects or negative effects. Do I think that the 3-day waiting period before increasing Strattera from 40 milligrams to 80 milligrams is too quick? So and this is more from titrating antidepressants and other medication and stimulants, my approach is, if you're having side effects that are significant or bothersome, if they're really bothersome, you should drop back. Even again, if you started with a low dose, maybe your body needs an even lower dose. So I would start with the low dose and drop back till you have tolerable side effects. And with Strattera, if you're not having any side effects, then 3 milligrams is a fine rate to go up from 40 to 80. If you're having side effects, I would sit at 40. Again, this is not a specific recommendation. This is a general informational answer. My approach would be to sit at 40 till it's more tolerable. We often find that a drug that was initially intolerable when pushed too quickly to a higher dose is completely tolerable if you circle back and more slowly titrate up to that dose. So James Alexander says the link between stimulant medications and Parkinson's risk is often explained as higher dopamine results in higher levels of dopamine metabolites like free radicals that are toxic to dopamine neurons and nerve terminals. If this explanation is correct, does that mean that dopamine increasing NRIs like atomoxetine and viloxazine also increase Parkinson's risk? Is that not a concern if that increase is limited to the prefrontal cortex? So one is that the number of studies linking increased Parkinson's to ADHD or to stimulant medications, there are a number of studies is pretty small to date. At least one, I think was a Utah-based study, was a sizable collection. Again, there's blurring as to whether ADHD itself may increase the risk of Parkinson's and that the stimulant use may just be a reflection or a side issue, and that there may be something more fundamentally aberrant about dopamine systems or concentrations or receptor densities or forms of receptors that are contributing both to eventually Parkinson's in some people and ADHD in others. So Parkinson's disease, to step back or make it clear for people who aren't into neurologic syndromes, is a condition marked by significant movement disorders, particularly a resting tremor and slowness of trouble initiating movements, frozen periods. And the hallmark is destruction of dopamine nerve cell bodies in the substantia nigra. And there's Parkinson's disease, and then there are Parkinsonian syndromes that mirror that or overlap lots of the symptoms there. If it turns out that the mechanism is messing with dopamine, this way stimulants mess with dopamine, then presumably other dopamine increasing norepinephrine reuptake inhibitors may have that risk. But I'd say right now we're more in the realm of speculating than knowing. James is citing one study that claimed that atomoxetine increases dopamine levels in the prefrontal cortex to the same degree as methylphenidate, but not in dopamine and dopamine transporter-rich areas. There's still a lot we don't know. So again, the differentiation or distinction is the cell bodies for dopamine cells are largely the locus coeruleus substantia areas deep in the brain. Effects there may be different than where the dopamine nerves project to in the prefrontal cortex or other areas. Again, with dopamine systems, there's what are considered three or four major systems. There's the mesocortical, mesolimbic, there's a hypothalamic, and there's the motor dopamine systems. And our drugs may again preferentially affect cell body regions or cell body regions distinct from cell terminal regions. So Max is asking, are there instances where you add on a mood stabilizer to a stimulant treatment for patients with ADHD? What factors would lead you to introducing that mood stabilizer? Mood stabilizers are a nebulous category. I mean, by definition, they are drugs that are stabilizing mood. Most of them were first explored in classic bipolar disorder. And the requirement is they are not just an antidepressant or an anti-manic agent, but they have preventive effects for keeping someone from entering into the opposite state or pushing them into one of those two states. The early mood stabilizers were lithium and then Depakote and Tegretol and a few anti-seizure medications, and then a number of the atypical antipsychotics were found to be mood stabilizers. And more so than many of our other drugs, and we can talk about it with stimulants, the mood stabilizers tend to have a lot of physical side effects. Stimulants have uncommon, really bad side effects, like some people get addicted, some people become psychotic. Those are in the range of 1 or 2% for addiction in most studies or lower, Rates of psychosis are less than 1 out of 500, which is, for such a serious outcome, really bad, but not particularly common. With the mood stabilizers, many of them are, a third of people are eventually having metabolic disorder or substantial weight gain or cognitive slowing. So as a class of drugs, I have a high threshold for starting it. In the setting of ADHD, also, there's studies done primarily by Russell Barkley and others looking at emotional volatility or emotional dysregulation, and stimulants can absolutely help with emotional regulation in people with ADHD. Now, too high a dose can make people more irritable, can make them more aggressive or angry or deregulated. So finding the sweet spot is important. So one of the factors that I would lead me to introducing the mood stabilizer, and one of the mood stabilizer that tends to have the most benign profile is Lamictal, lamotrigine. So weight gain, extremely uncommon. Sedation, quite uncommon. Gastrointestinal side effects, uncommon. Not likely to cause liver or kidney damage or thyroid damage, which other mood stabilizers can do. Lamictal's big issue, serious side effect, is that it can cause a dangerous rash, Stevens-Johnson rash, which can be fatal, but that's quite rare and is even less likely if you start slow and titrate up over a month or so. So that I have a somewhat lower threshold for considering, but I would try to see whether either stimulants or guanfacine might be addressing the mood issue first. Certainly, if the person had other health issues or pre-existing liver, kidney, other issues, that would certainly affect whether I want to introduce another medication at all, compared to someone who's relatively young and healthy. And certainly other factors would be important would be if other family members had responded strongly positively to a given agent. That suggests some genetic factor may be at play that is responsive to a certain agent. So those would be my general answers there. DD, I think, is getting back to some of the default mode network. Says overactivity is equal to less deactivation. If the precuneus is implied in other brain networks, would it mean that if there's less connectivity within the default mode network in the precuneus, less synchronization with other brain networks and results in an overactivation in the default mode network? To me, one of the important questions is whether the less connectivity was an activation question in terms of during a specific task, or was it a fundamental wiring study showing that the connection is really less strong or robust? Because otherwise, interpretation is going to depend on what specific task is going on. James Alexander is asking about how does my clinical experience inform the difference in titrating up Guanfacine versus Atomoxetine. Specifically, why spend a month between Guanfacine dose increase instead of just upping it when the side effects go away, like with Atomoxetine? My claim, and this is not in agreement with many of the experts in the field, the experts claim Atomoxetine works slowly. It works slowly because it's like an antidepressant and being just a norepinephrine reuptake inhibitor, and antidepressants work slowly. The reason people go up slowly with Atomoxetine is purely because of tolerance issues. It works as a reuptake inhibitor of norepinephrine immediately. From that basis, on a scientific level, we would expect it to work immediately for ADHD. And for my clinical experience, which is limited because I don't particularly, the side effect burden is so high for most people that they don't want to stick with it. But I've certainly seen a few people who had immediately, the day they took an effective dose, it worked. So the only reason for titrating Atomoxetine slowly is to make it tolerant in terms of its side effects. It's also why I use duloxetine almost all the time instead of it, because duloxetine just clinically tends to be much more Duloxetine is also a norepinephrine as well as a serotonin dual reuptake inhibitor, but it tends to be far more tolerable, and people can take a dose that's impacting ADHD, impacting it immediately. Guanfacine, on the other hand, all the available evidence is that it really does take a long time to work. And again, it's taking a long time to work because it's not just the binding at the alpha 2 noradrenergic receptors in the forebrain where glutamate is also acting. It's not the binding there that is causing benefits. It's that the binding there is changing how the cell is using glutamate and eventually leading to new synaptogenesis. I think I'll get her name right. It's Amy Arnsten's work at Yale behind much of this. So guanfacine really does take a long time to work, on the order of a month or two. So the rationale for titrating slowly with guanfacine is you have no idea what you're getting till you sit there for a while. It's not to make it tolerable or less tolerable. So I hope that distinction is clear. Can you go up quickly? Yeah. I mean, the downside is, one, if you push it too high, you may feel too much side effect, sedation or other side effects. And two, you may have blown past what is an optimal dose for you. So it's frustrating in some ways. You need to be patient with guanfacine to assess what it's doing. So Dee is glad to have the opportunity to talk to someone. And I wouldn't call myself a researcher, except at a literary research level. So I do have a full PhD in neuroscience, but I have not engaged in active lab bench neuroscience for 30 years. I have remained active and take a research mind to, as well as a clinical personal approach to patients I've worked with, and I've done a lot of reading. So DD adds that they've changed their diet to match the PK of their medication. So I do have a talk on acid-base balance, which is what DD is referring to there. So Khalid Ahmed asks, would I classify Wellbutrin as a stimulant? Most doctors prefer it to Atomoxetine. Any view on this? Stimulant, in its broadest sense, is any drug that's having sympathomimetic. So it's mimicking the sympathetic nervous system, which is essentially boosting norepinephrine systems, is the broadest definition. So a whole bunch of drugs are stimulants or have stimulant-like effects. But when we're in the ADHD world, we usually are referring just to amphetamine and methylphenidate products. On my talk on methylphenidate, I question why we even consider methylphenidate a stimulant. So the street stimulants, some of which are amphetamines or amphetamine derivatives, as well as amphetamine, not only are norepinephrine and dopamine reuptake inhibitors, they are also vesicular releasing drugs. So they are causing an extra large boost of neurotransmitter to be released. So by my classification system, amphetamine is a stimulant. Ritalin probably isn't and shouldn't be. But Ritalin, Wellbutrin, the others I would say is norepinephrine, dopamine enhancing drugs that have some sympathomimetic properties. So I'm reserving stimulant for giving an extra boost or release of chemical. So I'm not sure where Khalid lives. His experience is most doctors prefer Wellbutrin to Atomoxetine. I have talks in this channel both on Wellbutrin and Atomoxetine. My clinical experience is that Wellbutrin Buproprion is vastly easier to dose, more tolerable. People can much more readily get to an effective dose. Wellbutrin has both dopamine and norepinephrine reuptake properties, so theoretically it may be more potently or better matched to ADHD than Atomoxetine. Manufacturers, since it's been approved for depression, approved for smoking cessation in the US under the brand name Zyban, it costs millions of dollars to get an ADHD or other indication. There's just no incentive for them to have ever pursued it. But I would say that it's at least as good a drug for ADHD. Are there some individuals who may clearly get a better response to atomoxetine than to bupropion? Absolutely. Does that represent a large proportion of people? I don't see any evidence that it is or does. Mr. AKA says, theoretically, SSRIs, maybe not SNRIs, should worsen ADHD symptoms. What's my clinical experience? Clinical experience, I'd say, comes in two directions. So I've certainly seen people who came in for depression and were already on an SSRI when ADHD was previously missed and salient, and maybe at least as important as their depression. I haven't seen people very often clinically complaining they got worse on their SSRI, or again, if they weren't even aware that their ADHD was ADHD. Most often coming the other direction for someone whose ADHD is being treated and then SSRI is being added on top to address anxiety or depression that's still untreated. I haven't seen adding an SSRI causing overall worsening or exacerbation of his executive functions. In contrast to, and this is interesting, some of the tricyclic antidepressants, things like dopamine and nortriptyline, have some experimental evidence of being effective in helping with ADHD, particularly those that are working more on norepinephrine and maybe dopamine than on serotonin. On the other hand, overall, the tricyclics have a worse profile in terms of greater likelihood of impairing cognitive functions than the SSRIs do. The SSRIs have fairly low rates, particularly in the therapeutic range. Now, when SSRIs are boosted to high levels, certainly apathy can be common, certainly emotional flattening. So most often when I've seen SSRIs added to a stimulant for someone with ADHD, it's usually because they have depression or social anxiety or another anxiety disorder. And very often the addition has been helpful overall, and the people have been delighted at the combination. As an aside, I know at one point in time, I don't know if he still is, Daniel Amons, who is famous for charging thousands of dollars to get pretty PET scans of your brain and identifying 11 or 12 or 9 or 13 different distinct types of ADHD, very little of which has been able to be replicated by other research groups. I think there's a kernel of truth in what he does, but there's also a lot of hype. He claimed that there were some subtypes of ADHD that are preferentially responsive to SSRIs. Again, I'm not aware of other groups or people replicating that in a number of studies, failing to find SSRIs having beneficial impact in people with pure ADHD. So James asks, he knows many relatively intelligent people that get through undergrad on their smarts despite lacking any sort of study skills before failing out of grad school and then getting diagnosed with ADHD. How can they build such schools before trying grad school again or having a more successful run at grad school? My answer there would be to start with the schools. Large numbers of universities and colleges these days have study skills sessions because they know, compared to 20 or 30 years ago, not just people with ADHD, but general students are coming in with much less ability to read for extended periods of time, much less ability to extract key concepts from a passage they did read. So many colleges do have study skills, time management approaches that are particularly geared toward the academic environment, and many of them do a good job of it. I know there are many groups or people offering online training or teaching, and I just don't have enough. I don't know which of them are good and do a great job and which are scams, essentially. Separate from building up executive functioning skills, study skills, there are also an increasing number of coaching and other entities or organizations sort of farming out your executive functions to these coaches and or companies. So some of them review, did you do your homework today? Have you kept up with this? And we'll issue you reminders and hints and prods, and we'll sort of, again, can outsource some of your executive functions. That's probably less ideal in the long run, but it worked for someone who's president right now. Lots of expensive lawyers to do all the work and write the contracts that made him rich. He didn't negotiate those deals. He didn't write the contracts. So Daily Pigs, sorry for the third question. Wonder if EKGs are necessary before starting Strattera. I'm reading online that people have had strokes and heart attacks. My answer there is I am firmly against cover your ass medicine. I think part of the reason U.S. medical costs are on average twice about what they are in every other industrialized advanced country, and our results are poor, is because of the pervasiveness of ordering lab tests, which are unnecessary. So the cardiologists, the people who would be profiting from running more EKGs, have said, take a careful family history, take a careful personal history. If you've had episodes of fainting, if you have episodes of blood clotting, if you have episodes of weird arrhythmias, if people in your family have dropped dead of strokes or heart attacks in their 30 or 40s, absolutely get an EKG. Otherwise, the rate of it finding anything remotely rare, that it's not worth doing. So that would be my informational, again, that's not a specific medical recommendation. That is the information I would share. So Max asks, can every mental health condition be considered a spectrum? And if they are all spectrums, why establish categorical diagnoses rather than just treat symptoms? So I'm trying to think of whether something like a tic disorder, a tic disorder does exist on an order. There's a spectrum of how frequently, how impairing the condition can be, but I would say, are most people blurting out words or phrases or nonsense? I'd say there may be some conditions that are truly categorical. Again, even though there is a degree of severity within that category. But I'd say depression, schizophrenia, bipolarity, ADHD, anxiety spectrum problems, PTSD, everything I know of, and certainly personality disorders, and there's a big push on personality disorders that we should be avoiding or minimizing emphasis on categorical diagnoses. So again, the whole field is moving, and we're dealing with what we have now, and lots of bright people have spent their whole careers coming up with the system. Most of them acknowledge it's not perfect, but it's also not complete garbage. It does have some meaningful relevance in terms of offering predictions about what's likely to happen to certain people. It offers guidance in terms of what treatments might be effective, and it helps with understanding what's going on, both for the individual and the treatment team. So Carol asks, is rejection dysphoria explained by brain chemistry imbalance? So I have a whole video on rejection sensitivity dysphoria. I am not a big fan of the term. It's used both fairly narrowly and then fairly broadly, sometimes to refer to almost any emotional dysregulation. I am not aware of any research looking at brain neuroanatomy, brain chemistry, or even, there are claims that it's preferentially responsive to certain medications and not to others. That's one or maybe more than one individual's clinical experience, but I'm not aware of any research that actually speaks to any of that. So James asks, have I ever had a patient with severe ADHD experience full relief of their executive function or inattentiveness symptoms from Guanfacine monotherapy? So I would say I have never seen anyone with any drug completely eliminate symptoms of severe ADHD. I've seen people who have moved from highly impaired and dysfunctional to much better functioning, but I would say virtually everyone I've dealt with, we are moving them along the spectrum, but we are not eliminating ADHD. And one of the reassuring things is that some of the critics of meditation say these drugs turn everyone into zombies and flatten out all creativity and individuality. And I would say they don't, because the drugs are mostly working on neurochemistry, and probably most of ADHD is a wiring issue. Yes, guanfacine is probably clearly affecting wiring, but maybe not wiring in all the places it needs to be affected. So Beth asked what medication is similar to alcohol. She's on Elvance, which is Vyvanse list dexamphetamine, and doesn't drink alcohol anymore. But when she did, she felt confident and didn't suffer with such low self-esteem. The drugs that are most commonly compared, because they're working on the same GABA A subunit, not exactly the same way, but lots of overlap, lots of cross tolerance, are the benzodiazepines. But if someone is primarily coming in with pervasive confidence and self-esteem issues, my approach would be talking therapy, and probably SSRIs are what I would think of first to get at underlying anxiety, depression issues, because those are far less likely to develop tolerance and far less fraught with side effects and problems than the benzodiazepines, which are the Valium, Klonopin, Ativan, Xanax-like drugs. Thanks for being here today. Thanks for great questions. I hope I answered them well enough. I know some of them I didn't give answers that were completely convincing to myself, but stay healthy, stay happy. I will be back next week, same time, same channel.